concept and to introduce the judges for tonight for the arthroplasty session, I'll invite Dr. Sanjay Dhar, President of Bombay Orthopedic Society. Over to you, sir.
Hi, good evening, everyone. It's my pleasure and honor to be introducing you all for this first BOS Rising Star contest. This contest we have conceptualized with the help of many people in Bombay Orthopedic Society. This is the concept basically arose because we thought in all the conferences we have only senior members or existing faculty who are contesting, and there are always new, fresh faces who want to be faculty, who have a lot of work in their back on their and who want to present in the big conferences. So to identify these and recognize these young orthopods who are going to be the future leaders, we thought this platform would be a useful entity to begin with. So BOS has consented to host this contest, and we are lucky enough to have a very strong online platform in the form of ORTHOTV, who has also accepted to host this event and give their all wherewithal, their backup for this contest. So I welcome all the contestants and the judges. We have eminent orthopedic surgeons and joint replacement surgeons who are with us as judges. I'm sure they will be unbiased and very clear in their requirements. We have Dr. Milind Sawan, who is a well-known orthoplasty surgeon in Mumbai. We have Dr. Shubhranshu Mohanty, who is a professor and head of unit from KEM Hospital. And we have Dr. Anup Damangankar, who is a very young orthoplasty surgeon working in Mumbai, who has consented to be part of this contest as judges. We have a framework for marking these contests, and which I think we all shared with you. It will be presentation skills, research part of it, then how methodology has been adopted to the organization of all this presentation. So all this will be correct and will be taken up, and we will decide the winner of this event. This event will be ultimately in many episodes because we have tried to segregate these into orthoplasty, trauma, spine, and from these we will take winners which will go to the either next stage, and then final will be in Byrock during on the podium, where we'll have a final contest where we can choose this BOS star of the year. We have also prize money for this, which will be declared during the Byrock. We have many sponsors who are ready to sponsor this prize money, and BOS itself is ready to sponsor this prize money. So as we go in this next stages, we have almost, I think, Ashok, 45 contestants who are part of this.
42, sir.
Yeah, 42. But only issue is that this is right now only for BOS members. We have not left it open for rest of the people. So we are very strict in that. I request you once again, contestants, to be BOS members for this. Maybe next year we'll leave it open for rest, but right now we have kept it only for BOS members. So in case you have not become BOS members till now, you still have time to go and become BOS members, because otherwise we'll not be allowing this contest for non-members. So today's contestants are Dr. I think Ashok, you will declare that.
Yes, sir.
I will introduce.
Yeah.
So good luck to all of you, and I'm sure you will love it. It is not the contest. It is not the winner ultimately. It is participation, and the whole concept is basically that the younger people come to the front, and it has been always my desire to allow youngsters to come to the forefront, and we seniors need to allow that and make it happen. So I thank Ashok, who has taken great scale and spent a lot of time on conceptualizing this and giving it a full shape finally. And Dr. Neeraj Bijlani, who is always ready to help in this, and never ever he tries to put me down and take the whatever the difficulty is makes it happen. So thank you very much, everyone. Thank you, judges, particularly Dr. Milind, Dr. Subhranshu, and Dr. Anup, to be part of this. So all the best, and let the whole thing start. Thank you very much.
So now I'll invite Dr. Neeraj Bijlani, Secretary of BOS, to again say a few words and also introduce the contestants today. Go
So
ahead.
yeah, I welcome all of you. I welcome all of you to the episode 1 of the BOS Rising Star session. This is the Fierce Arthroplasty session. So we will have 4 speakers in this. The speaker names are as follows: Dr. Ashraf Shaikh, who will be talking on cemented versus cementless hip arthroplasty; Dr. Chandan S, who will be talking of use of tranexamic acid in arthroplasty; Dr. Sawankumar Pawar, who will be talking on dual mobility cups in hip arthroplasty; and Dr. Amit Garud, who will be talking on robotics in knee arthroplasty. With this, I hand over back to Ashok to start the program.
Okay, so let's start the Fierce Arthroplasty session. I'll request the first candidate, Dr. Ashraf Shaikh, to share his screen and start his presentation. So every contestant had, yes, sir. Shubhranshu, sir, you have a question?
Yeah, that's what I wanted to ask. Just how much time for presentation and how much time for question answer?
So 8 minutes for presentation for each candidate and 2 minutes for question answers.
Okay.
So go ahead, Dr. Ashraf, you can share your screen.
Okay.
And
Yes, sir. Thank you. I'll just start sharing my screen.
sure.
Is my screen visible?
Yes.
Okay, great. So I'll just start. Right. So good evening, everyone. I'm Dr. Ashraf Shaikh, Assistant Professor at Department of Orthopaedics, KEM Hospital. It really is an honor to kickstart this amazing initiative by Bombay Orthopaedic Society. And so let's begin the hip arthroplasty showdown. To cement or not? It all started when Sir John Chanley introduced the concept of low friction arthroplasty, which has really stood the test of time. It has shown excellent survival outcomes of 86% at 20 years, even 78% at 30 years. And that has been like a gold standard right now. The cemented stem basically gives immediate mechanical stability. However, in the 1970s, it was observed that there was some implant loosening cases that were seen, and that was attributed to the cement, and the term cement disease came into being, which even today, the basis of which is quite controversial. Nevertheless, it began the search for a biological fixation in the form of a cementless stem. This cementless stem has its own complications, and over time, improvement in the cemented as well as the cementless implant designs led to both performing quite well. So we stand here today. Hybrid arthroplasty is basically cemented stem with an uncemented acetabular cup. So I've searched electronic databases to include studies that are relevant in the last 10 years. Systematic reviews, meta-analysis, and comparative trials have been included. National registries that are quite relevant, for example, Sweden, the United Kingdom, and United States, they have been included as well. To be very honest, we do not have a very clear answer. On one side, we have the United States, New Zealand, and Australia who prefer cementless total hip arthroplasty. And on the other side, we have United Kingdom, Sweden, and other Scandinavian countries that are proponents of the cemented total hips. Now, there definitely has been a shift towards the cementless system over the last few years, which has reflected on in the registry trends. So Sweden, as we can see on this chart on the left side, that it has been the most common country that uses cemented total hip arthroplasty. However, even their rates have come down. Looking at UK, the most common fixation is hybrid, that is followed by cementless stems, and New Zealand follows the same. The probable reasons for this is that, especially in young patients who are more active, long-term outcomes of cemented metal on poly or cemented ceramic on poly as compared to the uncemented variants have shown increased rates of aseptic loosening as well as revision. And a lot of studies from all over the globe are suggesting this. On the other hand, United States, which is a big proponent of cementless stems, have started to acknowledge the use of cemented total hips in old patients, especially in old patients, that we can see with the increase in number of cemented stems that are being used in the elderly. Bone cement implantation syndrome is a very specific complication of cemented total hips. And in this landmark study in CORR in 2021, the authors have shown that the incidence can be as high as 5% of severe BCIS in total arthroplasty, and that leads to a more likelihood of death within the first 30 days of surgery, as seen in this Kaplan-Meier survival curve. This is another landmark study by Dan Berry from the Mayo Clinic Joint Registry. It's a 40-year experience with more than 32,000 primary total hip arthroplasties. They have had a mixed bag of cemented around 15,000 and uncemented around 17,000. They have concluded that intraoperative fractures occur 14 times more often with uncemented stems. Females more than 65 are at a higher risk, and post-operative fractures within 30 days after an uncemented stem, the rate was 10 times higher than the cemented stem. So it's clear that periprosthetic fractures are higher in the cementless variant. This is the largest cost-effective analysis that was conducted by Fawcett's. They have analyzed over 1 million cases from the National Joint Registry and the Swedish Hip Arthroplasty Register. And they have found that the most cost-effective option in cases that are less than 65 years is cemented ceramic on poly, and in more than 65 years is cemented metal on poly. They have not found any evidence to support that uncemented, hybrid, or reverse hybrid implants were the most cost-effective for any patient age group. The added advantage in a cemented total hip is that it potentially has lesser thigh pain, at least in the initial follow-up period. Sinking of the stem is possible. So this is just an example of a dysplastic hip that we had last week that we operated. And in this case, the patient had quite a narrow canal. So we ended up using an Exeter cemented stem, the smallest size available, and the patient had quite a good outcome. Changing version in hip dysplasia is also, it's also possible in uncemented, but that's quite a costly variant. The S-ROM stem would be quite costly, and it would be quite easier to do it with a cemented stem. They are also potentially easier to revise in cases of aseptic loosening because we can always go ahead with a cement and cement fixation in those cases. So this is the North Atlantic divide, where on one side we have the United Kingdom and the other Scandinavian countries, which have a government-funded healthcare and have to be cost-effective. On the other side, we have the United States and some other countries where market forces may be taking some driving force regarding the decisions. But we actually do not have to mimic exactly either of these because we have our own indications and we can follow literature as it is. So one size fits all in some situations and some cases, but that's definitely not the case for total hip arthroplasty, where every patient is different and choice of fixation can depend on a lot of factors. For example, patient age and activity status, the bone quality, cost, the training of the surgeon, surgeon's preference, or even the implant design. This is a very important slide where we would discuss the advantages of cemented and vice versa. So the advantages would be that it is definitely cost effective. It is good in osteoporotic and physiologically old patients. The disadvantages are that cementing technique is an art and it has a particular learning curve which needs to be developed. Loosening can be seen on a long-term follow-up in young patients. It does require a slightly longer operative time, and cement-associated complications are unique to this part. In advantages of the cementless total hips, it is quick, relatively easier to perform, shown to be better for young and active patients. More bearing options are definitely available because if we are, for example, supposed to perform a ceramic on ceramic implant, then it has to be a completely cementless implant. The disadvantage is, however, that there's increased risk of periprosthetic fractures. It is not wise to use it in osteoporotic stub pipe canal patients, and it is definitely costlier. Thigh pain was a concern in the earlier variants of cementless and a slightly lesser now. So all of this information in such a short time can be a little daunting and maybe confusing. So if I am to summarize all of this into one slide, then I would just like to say that cemented is a very good option in cases that are more than 75 years of age physiologically. Cementless perform slightly better in less than 55 years of age. And from 55 to 75 years, both of these implants have stood the test of time and they have performed quite well. The future research probably would be, according to the registries as well, it could be directed into the directions of the sizes of femur head that we use for these total hips and the bearing that we are using as well, the ceramic on poly or ceramic. And whatever implant does come, it has to stand the test of time of 95% at 10 years. That's the gold standard. These are my references that I've used for my presentation. And I thank the Bombay Orthopedic Society, Dr. Sanjay Dhar, Dr. Ashok Sham sir, and Dr. Neeraj Bijlani sir for this opportunity. Thank you.
Thank you, Ashraf, and thanks for finishing in time. You took 7.5 minutes to finish it. I'll hand it over to judges for question and answers, so you can stop sharing your presentation. Over to you.
Yes.
So I think we three of us will ask one question since 2 minutes time is there.
Sure, sir.
Let me start asking Ashraf. Good
Yes, sir.
presentation, Ashraf. Good literature review. My question is, tell me single most important factor which you will consider whether to do cemented or uncemented. Single most important factor. One factor only will decide that whether you will do so. We don't consider, cost as an issue. You don't consider other
Yes.
factors as an issue. You don't consider age as an issue.
So activity status of the patient is what I would say. If the patient is active, if the patient is quite active, then we would like to prefer a cementless implant, and then slightly inactive patient requiring less activities we would like to prefer a cemented implant for that.
The bone quality is the single most important factor.
Yes.
Okay.
Yes, sir.
Even in young patient, cemented has done well, as you showed in the literature. Cost also not an issue. So it's the bone quality which you'll see. Even in young patients in a DOR type C canal, you'll prefer a cemented. Even in an old patient beyond 75 years, if you see a DOR type A canal, you will prefer a uncemented probably. Okay, I hand over to Namilin.
Yeah, Ashraf, congratulations. Nice presentation. You quoted a paper by Dan Berry.
Yes,
Berry, it mentioned increased incidence of fractures for uncemented. Now, did
Yes, sir.
these fractures need a second surgery, or were they just identified post-operatively?
So some of them were intraoperative fractures and the others were post-operative. The ones that were post-operative, 36% of them required a revision of the total hip arthroplasty, and the others some of them were conserved and the others were fixed either with some fixation method. But 36% of them did require a revision of the total hip, sir.
36. Okay, thank you.
Dr. Ashraf, a good presentation.
Thank you, sir.
So I'm going to hand you over a situation in which you're doing a total hip in a 62-year-old person. You've planned to do, let's say, type 2 stems. I wouldn't name the company, but you're doing an uncemented stem. And you fit in the stem and you're reducing the stem. You dislocate the stem and check for stability. It is rotationally unstable. Okay. So what do you think is the reason and how would you tackle this situation? Are you clear with the situation scenario?
Yes. So I've reduced the total hip and it's dislocating rotationally.
It's unstable once you dislocate after a trial reduction. So what are the reasons and how would you tide over the situation?
So
I'm sure you must have faced this situation.
Yes, sir. So if I'm checking for the stability of the hip implant after reduction of the implant of the trial implant and it's dislocating in rotations, so I would suspect any kind of acetabular version problem that I have put the acetabular cup either in slightly more retroversion or anti-version depending on where the dislocation is. So that could be one of the reasons, the acetabular version. And secondly, on the femur side, it may be that my horizontal offset or my vertical offset is off, and I would like to correct that as per my pre-op planning or before I took the cut for my stem. So the reasons could be either on the acetabular side or it could be on the femur side. If it's on the acetabular side, it could be it could be my acetabular version. If it's on the femur side, I could be off by either a horizontal offset might be off or the vertical offset, depending on that.
The question is, after you have a trial reduction of a well-fixed stem, a trial stem, okay, you reduce the hip, you dislocate, you find that the stem is a little rotationally unstable.
Okay.
I'm not talking about the acetabular.
Okay.
How would
The
you
stem is
tide over
unstable.
that situation? Yeah. So understand the situation.
Okay. Right.
Okay.
Sorry, sir. I just understood. So if the stem is rotationally unstable, then it would be better to go in a larger size now rather than using that stem, because there's a chance of stem subsidence. So I would remove that tile stem and I would put the next size, and then I would check it again if the stem is rotationally unstable in the canal.
Okay, so have you heard of metaphyseal diaphyseal mismatch?
Yes, sir.
Okay, so that is one of the commonest reasons where you face this situation. If you do not ream the metaphyseal diaphyseal junction and upsize, you may have a proud stem. In this situation, you have only two means: either you ream and put in a higher stem in, which is uncemented, or else you strip to a
cemented stem. Okay, sir.
Okay, so I think that is a point that is very important when you determine when do you want to do a cemented or an uncemented stem. Okay, but good presentation overall. It's like comparing apples and oranges sometimes. You can't really have one
actually,
solution.
it was very difficult to jot all of that down in 8 minutes because the data was so varied. And even today, there's conflicting data on cemented and cementless, where even today we're getting papers that cemented is performing as well even in the young. So it's a little still in the gray area.
A few studies from our subset of Asian population will be very important in this regard. I think they're coming up. So I think we should have some Indian data.
Actually, I didn't have time actually to include a couple of studies from Korea. So 2 studies from Korea. Both are contradicting. One from the Joint Replacement Center, which says that 30-year follow-up of patients, they say that cementless and cemented is the same. There's no difference. And the other study has said the exact opposite thing, that cementless performs way better than cemented. And they are from South Korea itself. So it's a little.
If you draw a timeline barrier of papers beyond 2012. Or 2014, you'll find a stark difference, because that is when your polys have gone better suddenly. So all those papers are redundant.
So Subhranshu sir wanted to come in.
No, I just if I'm permitted to ask one more question.
Sure, sir.
Yeah, Ashraf, did you find out from the literature whether uncemented stems can cause a bone cement implantation like syndrome? You didn't mention that.
Yes, sir. From my review of literature, I couldn't find any such reference actually, sir. Where I read about the article that I quoted. In this article, they had actually only taken the cemented variants of all arthroplasties, the knee, hips, and even the revisions. But while doing my review of literature, sir, I couldn't find any reference regarding BCIs in an uncemented stem, sir.
Yeah, there is a possibility of development of also in uncemented stems, so it causes this kind of syndrome.
Okay. Thank you.
Thank you, Ashraf.
Sure.
Well done.
So let's invite our next contestant, Dr. Chandan.
Yes, sir.
Yeah, go ahead, Dr. Chandan, if you share your presentation. So I'm timing the presentation. So if you go over 8 minutes, I'll inform you.
Yes, sir. Good evening, everyone. I am Dr. Chandan, fellow in Orthoplasty from Sunshine Bone and Joint Institute under Dr. Guru Reddy, sir. At the outset, I would like to thanks Bombay Orthopedic Society for giving me this opportunity. My talk
in the presentation mode, because it's still not showing in the presentation.
Yes, sir.
Yes.
My talk is on use of tranexamic acid in arthroplasty, a review of its role in reducing blood loss during surgery. Coming to introduction, joint arthroplasty is considered one of the most successful operations which relieves patient symptoms and improves quality of life. Reducing the perioperative blood loss and transfusion demand has always been the problem with the operating surgeon faces. Over the past few decades, many interventions have been developed to address this problem, such as controlled hypotensive anesthesia, blood recovery techniques, drain clamping, as well as application of erythropoietin and other antifibrinolytic agents. Coming to tranexamic acid, is a cis-trans isomer with a molecular weight of 157. What it does, it binds to lysine binding sites of plasminogen, thereby preventing its activation into plasmid, thereby degrading of fibrin degraded products. The common oral recommended dose is 500 milligram tablet, which is commercially available. The IV dose recommended is 10 milligram per kg body weight. As it is mainly excreted by renal system, its dose should be monitored accordingly. The search strategy included where the searches of PubMed, Medline, Embase, Google, and Google Scholar and the Cochrane library were used. Over 248 results were found, but we included those which contain compared Tranexa versus placebo and outcome including total blood loss and drain output and any post-operative complications. The purpose of the systemic review was to investigate the evidence for efficacy of TXA in reducing blood loss and transfusion requirement in patient undergoing arthroplasty and the evidence for any increase in complication rates. So in the various RCT designs, we can see that there is a total reduction in mean total blood loss and mean units transfused. In all of the RCT, we can see that there is a mean reduction in blood loss. In RCT by Giordis et al., where number of in placebo patients were 431, the mean unit blood loss, mean unit transfused was 2.4. In topical use of Tranexa, it was almost 0. This is in total knee arthroplasty. In other RCT by Indian study by Pachuria et al. Showed that there was reduction in HP drop, where the type of intervention was first dose was 1 hour post-op and second was 6 hour post-procedure. All these RCTs have shown that there is a reduction in total blood loss following use of TXA. Compared to coming to the effect of TXA on blood loss and transfusion in total hip arthroplasty, there are many RCTs which have shown there is reduction of mean total blood loss and mean units transfused. Comparing the placebo versus topical or IV, all the RCTs have showed the upper hand of use of TXA. So the results of meta-analysis were there was drastically decreased in HP drop, SCT, hematocrit drop, and drain output, and there were no much reported thromboembolic complications. So the results are the efficacy of topical dose. The topical tranexamic acid showed decreased blood loss in patient undergoing arthroplasty. Efficacy of IV dose, the IV dose has always been superior and has the strongest antifibrinolytic effect. Compared to topical, IV TXA can be more effectively in preventing the formation of fibrin plug. Combined topical and IV, many RCTs have shown that significant reduced post-operative bleeding and hemoglobin level. Intra-articular versus intravenous, the intra-articular administration was also effective in reducing blood loss and drain volume, but the IV administration is superior compared to intra-articular and combined intra-articular and intravenous. There are other RCTs comparing 2 gram versus 1 gram, and they have shown that 2 gram was superior to that with 1 gram. And they have shown that repeated dosing, that is 2 doses, produced a maximum reduction in blood loss. And they have also shown that even 6 doses of TXA has not resulted in thromboembolic events. Cost effective, it is a cost saving measure secondary to reduce transfusion related expenses. Optimal route and safety in comorbid conditions. 2 IV TXA dose and combination topical IV and treatment was more successful therapeutic for diabetic and obese patient where BMI was more than 30. The TXA appears safe in patient with history of thromboembolic, cardiovascular, and cerebrovascular events. Coming to wound closures, less blood loss in drains after applying TKA to suprapatellar space using the control approach prior to tourniquet was observed in many RCTs. Post-op doses, repeat doses up to 24 hours can lessen total blood loss, giving more fibrinolysis and inflammatory control. Even in revision scenarios, all TXA regimen may be topical, intra-articular, periarticular, or IV has showed comparable blood sparing abilities. Coming to conclusion, the tranexamic acid in arthroplasty, the search for holy grail of blood conservation in orthopedic surgery has shown reduction in perioperative and post-operative bleeding, decreased need for blood transfusion and its related complication, safe and doesn't increase any VTE rates. It's cost effective and reduces the length of hospital stay. So there have been many debates regarding the complications of TXA. In the Journal of Arthroplasty, a retrospective case control series of 38,222 patients showed that TXA to high-risk patient was not associated with statistically significant increase in serious adverse outcome compared to high-risk patients. And there has been also a debate regarding topical versus IV. In this RCT, we can see that given that therapeutic systemic levels of TXA were achieved with topical and that of mechanism of action, coagulation, and fibrinolytic profiles were similar between topical and single dose IV, but it is easier and simpler to use a single IV TXA when safety is a concern. Reference, sir. Thank you, sir.
Okay. Thank you, Dr. Chandan, and I'll hand it over to judges for questions.
So, Chandan, nice presentation.
Yes, sir.
You have done a good literature review. Just can you tell me what are the contraindications of using tranexamic acid?
Sir, any like cerebrovascular, cardiovascular, stroke, any these kind of are and the anaphylaxis to tranexamic acid. The major complications being increased bleeding tendencies like cerebrovascular diseases or cardiovascular diseases like MI, those kind of cases, sir. Okay, like stroke patients.
And in every cerebrovascular disease that you will avoid using tranexamic acid?
No, sir.
Stroke patients, which kind of strokes? Thrombotic stroke or hemorrhagic stroke?
Hemorrhagic stroke. Like even though these are the relative contraindication, use of TXA has not related any adverse serious related outcomes, sir.
Okay. And number two,
yes, sir.
Your center, you do bilateral TKRs?
Yes, sir.
Okay. So whether you use tranexamic acid with these patients?
Yes, sir.
Whether you use thromboprophylaxis?
Yes, sir.
So how do you counter that you use tranexamic acid also post-operatively and thromboprophylaxis also?
Sir, in our center, we use only one preoperative dose of tranexamic acid, sir. And we have good results only, sir. Post surgery, we do not give any Tranexa, sir.
So it's only for intraoperative blood loss reduction. You don't want post-operative blood loss as well.
Post-operative, we do not repeat any dose in our center.
Okay.
And we don't use any tourniquet or anything.
Thank you. Billing.
Yeah, good presentation. No questions. Thank you.
Yes.
Yeah, I have just 2 points. As Dr. Mohanty sir mentioned, you had referenced a paper in which they had repeated dose at 24 hours after a joint replacement.
Yes, sir.
Okay. Would you shed light on, would you give tranexamic acid 24 hours after the surgery, or would you focus on VT prophylaxis? One. Second question is, how early before the surgery would you give a preoperative dose, or would that count as an intraoperative dose? Are you okay? I'm talking about the IV tranexamic acid.
Yes, sir.
So would you consider a preoperative dose, or would you give an intraoperative? Once you open, will you give your tranexamic acid?
Sir, I would consider giving a preoperative just before the skin incision and before tourniquet inflation.
How long before?
Just before the skin incision, like exactly.
Okay, literature says 20 minutes before the surgery. That's when we need to give tranexamic acid.
Yes.
Secondly, have you had any references of patients having wound complications after intra-articular tranexamic acid?
Yes, sir. I have read an article regarding intra-articular injection of tranexamic acid relating in staphylococcal infection.
Right. So in your center, do you use that, or would you just give one parent?
One IV dose we give, sir, in our center.
Okay.
Mohanty sir, you have a question?
Yeah, you didn't quote Indian studies on this, Dr. Maniyar's paper on this. Have you gone through that? The comparison study of IV tranexamic acid, IV plus intra-articular, then IV plus intra-articular plus post-operative tranexamic acid. There's a beautiful comparison study, and which one is doing best?
Yes, sir. I look at it.
Okay. So intra-articular means, do you give intra-articular injections directly instilling into the joint, or you give injections into the periarticular tissue?
Into the periarticular tissue, sir.
Injections. You don't instill into the intra-articular, inside the joint.
No, sir.
Both have got equal effect.
Yes, sir.
Periarticular. So inside the joint, or you inject into the periarticular tissue, both have equal joint.
Yes, sir.
Okay. Thank you. Thank you for a good literature review of tranexamic acid.
Thank you, sir.
Okay, so let's move on, and I'll invite
So what was the
Dr.
timing for Dr. Chandan? Timing of presentation?
7 minutes.
Okay, thank you.
Yeah. So moving on, let's invite Dr. Sawankumar for making his presentation. Go ahead and share your screen. We can't hear you, so unmute yourself.
I'm audible, sir?
Yeah, you're audible.
Okay. Is it visible, sir?
Are you using the share with the mobile screen or optimized for video?
No. Laptop. I'm using from laptop, sir.
Okay, go to presentation mode. Just check.
Yeah, it's now visible, sir.
Still coming. Just a minute. No, it's not visible. So you have to stop share. And when you
No, Ashok, what he will have to do, he'll have to minimize the videos. Stop the screen share.
Yeah.
Yes. Now just follow step-by-step instructions. Click on share.
So click on the share screen.
Yes, sir.
And then you share the first option. The
Share.
Share the PowerPoint. Na?
first option on the
First option,
Can you see
PowerPoint.
that? You have to reply
Yes.
to us.
Yeah. Yeah, go ahead. Share the PowerPoint.
Now, sir.
Yes.
Yeah. Yeah.
You have.
Yes, sir.
You have to minimize the videos, whatever you're seeing on the screen. Or just drag them on the side.
That above zoom bar is there now, that is coming.
So pull it down, the zoom bar that you can see on your screen.
Yes, that bar, right.
Just pull it down, right click and pull it down. It will go down. Go down more.
It's not going.
Okay, pull it on one side if possible. Any side. Okay. Okay, fair enough. That's fine.
Yeah. So my topic is regarding the use of dual mobility in arthroplasty, its effectiveness and the rate of dislocation. So coming to the introduction part, India as a developing country has made a rapid growth in joint replacement surgery. And with the increased recent survey, it has been estimated that the number of hip arthroplasties are going to increase from 2020 to 2026. But as the number of joint replacements are increasing, there is also an increased trends of revision joint arthroplasty surgeries in near time. What causes So what causes the revision in THR? This is a review literature as done by Casito et al. He has studied 9 joint registries, and he has found that the loosening to be most common cause for revision hip replacement followed by dislocation. Whereas the instability or dislocation stands third in Indian scenarios. The dislocation at the end of first year is up to 4% in patients undergoing primary THA, whereas it is up to 25% in patients undergoing revision THA. So what are the factors which causes dislocations? These factors can be divided into 3. Patient-related factor, implant factors. Is it visible, sir?
Yes, go ahead.
Yeah, it's a patient-related factor, procedure-related factor, and implant-related factors. The procedure-related factor could be the surgical approaches, the component positioning, and soft tissue tensioning during the intra-op and surgeon experience. The implant-related factors is the femoral head size and head-neck ratio, whereas the patient-related factor is the female age with advanced age, with increased BMI, neuromuscular conditions, hyperlaxity disorders, or spinopelvic mobility. These are the patient-related factors which cannot be managed by the surgeon. So most of the advancement has been done in procedure and approaches and component positioning, but still there is a 58%.
Is your slide not moving?
Yes, sir, not moving. Yeah. So different strategies and techniques have been developed to reduce the risk of instability, most commonly used by Ranawat suture technique for the posterior approach. And there is a design modification to prevent the dislocation in terms of increase in femoral head size, constant liner, and to keep the cup in the safe zone. Even if the cup is placed in a safe zone, there is still a literature suggesting that there is a 58% of chances of dislocation. So hence the dual mobility concept has gained the more interest amongst the clinician. So this concept was developed by the Gilles and BOS, a professor from the orthopedics surgeon from France, and his friend Rambert. He has the combined Chandan technique of low hip arthroplasty with using a low small size head, 22 to 28, to reduce the wear effect. And second concept he has used of Mackie-Ferrat's principle of using a similar head of dimension that of the native femoral head, which articulates with the poly, and it reduces the instability. So the biomechanically, the hip dual mobility has a 3 articular surfacing. The first is between the cup and the liner, and second is the between the head and the liner. Most of the movements occurs in between the head and the liner, and second most at the extreme movement it occurs between the neck and the liner. This is the third articulation in which the initial stages of dual mobility has got a wear effect. So there is a concept of a jump distance in hip arthroplasty, which is a lateral translation of the femoral head during the dislocation. It is a minimum distance which is required for dislocation. So in dual mobility, the jump distance has been increased. This is because of the native diameter of the cup increases in relative to the polyethylene liner. Hence, the dislocation rates are less in the dual mobility. So the objective of the study is to find the role of dual mobility in different hip pathology and its usefulness in preventing the dislocation. Going to the methodology part, we have done the comprehensive assessment through the literature through PubMed and Google Scholar with a search term including dual mobility, THR, revision, and dislocation. Finding a relevant data search, it was 475 articles, of which 8 were evaluated. These are the study done by Darrett et al. In a systemic review. He has evaluated 54 articles in which 10,000 primary hips and 3,008 revision neck of femur patients underwent THR with a dual mobility cup. And the outcome had shown the lower dislocation in patients with dual mobility cup. Similarly, with the Nestler et al., he has done a retrospective study in 93 patients with lumbar spine fusion undergoing a THR with dual mobility cup, and he has shown that there is no case of instability with dual mobility cup at the end of 3.7 year follow-up. Similarly, Harvin, he has done a review literature study in patients with high-risk patients with neuromuscular disorder, and he has found a similar outcome result. There is no dislocation with dual mobility cup, and he has shown a better survivorship as compared to the standard fixed bearing cups. Wexner et al. He has done a prospective study in patients undergoing the revision surgeries of 994, and he has found the low dislocation rate of 1.5% at a follow-up of 7.3 years with dual mobility cup. Similarly, Romangirlol et al. He has done a systematic review, and he has evaluated the 15 studies and evaluated and came to the conclusion that the lower risk of dislocation with the dual mobility cup, even in patients with high risk and revision scenarios. So these are the studies. It has showing that the encouraging results in high-risk patient also that dual mobility cup has a better outcomes. This is the same Nestlers we have studied with 93 patients at a 2.7-year follow-up. And this is a neuromuscular study in patients with neuromuscular disorders studied by the Harvin et al. So Vagrants et al. Has reported the same dislocation rate of 1.5% at 7.3 years with the patients 994 going revision with dual mobility cup. So this is the recent study. This is during my fellowship was done at BOS et al. It's into the final stage. We have evaluated almost 378 patients with complex indications and 7-year follow-up. Still, there is no dislocations at the follow-up of 7 years. These are the few examples which operated. This is the post-polio residual paralysis patient underwent with dual mobility cup. Second is multiple sclerotic patients, spasticity in all 4 limbs, underwent with dual mobility cup. This is a patient with a proximal femur of tumor, underwent with managed with a dual mobility cup. Second is the monomolic polytrauma, which had a mixed fracture dislocation, has been managed with dual mobility cup. This is with the patient with the fixed spine with the small impingement concern, so managed with dual mobility cup. This is a fibrous enclosing patient with a small socket with 44 cup. This is a young 24-year patient with a septic arthritis at the age of 6 years with a high hip center managed with a dual mobility cup. This is in case of dual mobility cup in a revision scenarios. This is a dislocated hip managed with dual mobility, and this revising ASR, large femoral head with dual mobility cup. This is the study done by the Baiklin et al. He has studied a comparative analysis of time of dislocation between fixed bearing and dual mobility, and he has found that the proportional relative risk between the dual mobility and the fixed bearing is of 0.4 and 0.2. This is a series of 355 patients who underwent the revision surgeries, a comparative analysis between dual mobility and large femoral head size. They came to the conclusion that dislocation rate was 3% in patient undergoing with dual mobility group as compared to 10% in patient undergoing with large femoral head. Whereas the re-revision rate for dislocation was 1% with dual mobility cup, and that was 6% in patient with large femoral head. This shows that like increasing trend of use of dual mobility cup in revision cases and high-risk patients. This is the joint registry done by Cassiton et al. He has studied the various joint registry, and he has come to the conclusion that the number of percentage of joint dual mobility cup used in the primary as well as in revision cases has been increased over a period of time. Recently, it has started in the last decade, 2009 in America after getting FDA approval. They are also almost in a decade time, they are increased from 0.2 to 8.6% for primary hips and from 4 to 22.3% in revision hip arthroplasty. So coming to the conclusion, like dislocation is a catastrophic complication not only for the patient but also for the surgeon. So this has a good important tools for the surgeons to manage in patients with abductor deficiency or neuromuscular disorders, or patient with revision with instability, or the patient who have got the higher chances of dislocation. But in case of the younger patient, the higher wear perspective must be kept in mind and should be used cautiously. So coming to the take-home message, the long-term results are yet to follow. 10 to 20 years results are lacking. Modularity of dual mobility can use metal wear and eventually lead to the revision surgeries. Regular clinical and radiological follow-up and on indication on metal on testing is need to be followed up. With the increased use, we can expect that an increase of known and new complication can be expected. Thank you.
Okay. So thanks for the presentation. I'll hand it over to the judges, and just for the timing, he took 8 minutes 30 seconds. So that's about the time. Over to you, Monty.
Okay. There are some technical glitch.
Yeah.
Yeah.
Sorry, sir.
Go ahead.
Thank you, Sawankumar, for the literature of dual mobility using a ceramic head and a metal head.
Sir, literature between ceramic head and
Sir, your voice is breaking. We can't hear you properly.
Sorry, my voice is breaking?
Yes, sir.
Okay, sorry. I'll repeat the question.
Yes, sir.
So, Shravan, have you reviewed the literature about using a dual mobility cup in using a ceramic head and a metal head? Is there any difference or they are same?
Yeah, yes.
Nowadays, the oxynium head has also come. In
Yes, sir. Yes, sir. So the major concern with the dual mobility with the metal head is regarding the metal losses. That's the difference which has caused to come up with the newer generation of the dual mobility cup, which we got a ceramic and now we are up to the oxynium heads.
Why metal losses will occur? There is no metal and metal articulation. No? There is a polyethylene.
This could be this could be the third joint movement when at the extreme range of movement, the neck, head neck, this liner and neck attribution might be causing the metal losses and all.
No, the neck is impinging against the polyethylene, not the cup.
Okay.
So metallosis is not a issue with dual mobility cups. have you gone to the recent literature that are why dual mobility hips are the incidence is going down in United States?
No, sir.
Okay. So what is your indication today using dual mobility in your practice?
Sir, in consideration of my practice, I would be consider dual mobility in very high risk patient with mostly with neuromuscular disorders and with fixed spinal pelvic indication. Dual mobility will work better.
And why we are not using it in every case if it is prevents dislocation, and why each and every case we should use dual mobility?
Sir, certain concern regarding the intraprostatic dislocation is there in few cases. So that could be the reason, like we can avoid using in every cases.
Is there any difference of cup position in dual mobility and conventional total hip replacement? Is there any difference?
Conventional we got a play. We can fixed in a required angulation like inclination and aversion. Whereas in dual mobility we don't have that play to place the cup in a proper position.
But you are putting the cup first, then you are using the stem and all, no?
Yes, sir.
So in dual mobility, do you put the cup in little? You accept little bit of errors, or is it okay?
We can accept. We can accept, sir, in dual mobility.
Okay, Milind, over to you.
Yeah, so your presentation was so good that I'm convinced I should be doing only dual mobility. So tell me, why is not everybody doing dual mobility? What is the disadvantage of dual mobility?
So disadvantage is like the I guess surgeon experience required in dual mobility during the cup, and second with concern with like intraprostatic dislocation, and these are the two I think so most commonly which prevent the surgeons to going for dual mobility.
Okay, thank you.
Thank you, sir.
Very good presentation, Dr. Sawankumar. So I think, yes, you put it forth very well about the comparison of when do we need to do a dual mobility in select cases. The question that I wanted to ask is, do you know what metals are being used for the dual mobility shells that are in the market right now? And what is your preference as regards that?
Initially, there was a cobalt chromium. Now we have got a second and third generation with hydroxyapatite and porous coating cups.
But are they titanium or cobalt chrome or steel? And what is your preference?
Steel one.
In all of them?
One, sir.
Correct. In most of the companies, they use steel cups or cobalt chrome liners, as we know. And backside wear is something that is really significant. So you put forth well that in young patients, we may not be using dual mobility cups.
Yes,
so I think that's a good take home. And therefore, that is the reason why it's not being so popular amongst the surgeon panel over the world. So good presentation overall.
Thank you, sir.
That's it from
Thank
my
you,
side.
sir. Thank you, sir.
Okay, so thanks, Dr. Sawankumar, and I'll invite our last presenter today, Dr. Amit Garud, to share his presentation and start with his PowerPoint. Go ahead, Dr. Amit.
Yeah, so can you hear me?
Yeah, we can hear you.
Yeah. Okay, so first of all, I would like to thank BOS for giving us this amazing opportunity to present. And I would also like to congratulate all the previous speakers for their excellent presentations. So my topic for presentation is robotics.
Your presentation is not shared. We can hear you, but your presentation is not shared.
Just a sec.
Yeah. Yeah.
Okay. So is it visible now?
Yes, it is visible now. Go ahead.
Okay. So my topic is robotics in knee arthroplasty. I am Dr. Amit Garud. So to start with, as we all know, end-stage knee arthritis is effectively managed with total knee arthroplasty. We have been doing huge number of arthroplasties in India, somewhere around 2 lakhs per year. And we also achieve a pretty good patient satisfaction rate, somewhere between 82 to 89%. But there is still a significant number of dissatisfaction rates, which is attributed to poorer limb function, component malalignment, soft tissue imbalance, and other routine TKR complications. Around 32% of conventional TKRs land up in alignment errors greater than 3 degrees. So in desire for a better success rates, we have come to something called as robotic knee arthroplasty. So conceptually and theoretically, robotic surgery should enable greater accuracy and high reproducibility, which in turn may improve the outcome. So objective is to review the current status of knee arthroplasty. So articles in PubMed Central were searched with the keywords of robotic knee arthroplasty and robotic assisted knee arthroplasty, and relevant articles were studied to develop this narrative review. So evolution, the first generation robotic systems were introduced in early 2000s by USA in name as Robodoc, and in Germany as Casper. Both were fully active image dependent systems. However, longer operative time and technical failures, intraoperative complications lead to cessation of their use. Currently, we have a lot of other robotic systems in market. So to broadly understand robotic designs, we have something called as open system and closed system. So open system where the robot only takes the cuts, which is not specific to particular implant companies. However, in this type of system, there is a greater chances of component malpositioning and component loosening due to incongruous cuts. In case of closed system, the cuts are more implant specific, and therefore there is a lesser chances of malplacement of the component. Then there is image dependent systems and imageless systems. It is based on whether preoperative CT scan is used, or sometimes even MRI is used for planning of the cuts. So this is an example of a preoperative planning of the cut. This is an example of a Mako type of system where we use 3D reconstruction models also to plan and size the components. In case of imageless system, what we do is there is a handheld probe by which we give input during the registration process and mapping. And however, this is not that well accurate sometimes because it is subject to human errors. Then other robotic designs, it's passive, semi-active, and active. Passive is simply a computer-navigated technology which gives only a positional guidance to the surgeon, and there is no haptic feedback, and it has a high potential for human errors. Semi-active is it provides a real-time guidance to the surgeon while performing dissections. It is one of the most commonly used system in today's date. It can be haptic or non-haptic constrained. Well, active system is something where the cuts are actually taken by the robots. What surgeon does is surgeon performs the initial surgical exploration and positions the retractors and fixes the limb to the holding device. And however, surgeon can actually override the robot via an emergency button. And then we have something called as saw-based, cutting jig-based, and burr-based. So in saw-based, the saw is attached to the robotic arm, and the cut is taken by the robot, which is controlled by the surgeon. In a cutting jig-based, the cutting jig is attached to the robotic arm. The robotic arm places the cutting jig exactly in the plane where the cut is supposed to be taken, and then the cut is taken by the surgeon by a freehand saw. And then there is burr-based, where the resections are taken using robotic arm burr. And commonly available robotic systems in what we have in market is one of them is Mako, and then we have Navio and Cori. Mako is a Stryker system, Navio and Cori is a Smith and Nephew, and Rosa by Zimmer Biomet. All three are semi-active type of robots. Mako is image dependent, while Navio and Cori are imageless. Rosa is actually a combo where primarily it is imageless. However, you can plan it pre-operatively by a simple plain X-ray, which is converted into a 3D virtual model. And then, yes, Mako has a pre-operative planning ability, while Navio and Cori can be planned only intra-op. And Rosa, again, pre-op, partially you can plan pre-op, but however, confirmation is done only after mapping in post-op. Then resection types, Mako is saw-based, as we saw in the first type, and Navio is a burr-based. Now the burr here in Navio is a smart burr, So whenever we go to towards the cut, and whenever there is the cut is going beyond our planned area, then this burr slows down, stops, or sometimes retract. So that is how this robotics work in case of Navio. And in ROSA, it is just saw based, so there is no haptic. So it only places the jig. So whatever cut is taken is dependent on the surgeon. Then there is another company, Omnibotics, which additionally gives a balance bot, which is a robotic assisted spacer, which is used for calculating ligament tension and flexion and extension gaps. So the advantages of robotic systems is we have improved accuracy in implant positioning. We have reduced outliers in limb alignment, better ligament balancing, lesser need for soft tissue release. We can actually achieve desired alignment like mechanical, kinematic, restricted kinematic, or functional alignment. There has been studies showing significant blood loss and even decreased risk of post-operative blood transfusions. And there is minimal to no learning curve as far as planned implant positioning is concerned. Then there is reduced risk of iatrogenic injuries, post-operative pain, duration of hospital stays. And as far as learning curve is concerned, we actually we can divide it into two parts. One is accurate implant positioning part and the operative time part. So accurate implant positioning part, there is no learning curve in case of robotic. However, operative time, the learning curve is around 7 to 20 cases. So what happens is in initial few cases, operative times have been found significantly higher. But this is due to orientation to the robotics, its software registration mapping process. But many studies say that after initial 20 cases, it has been observed that robotic and conventional TKRs have a comparable operative time. Some studies, there is a Smith et al. Study which is a study of around 30 cases, which showed that conventional TK has just 1 hour 26 minutes, while robotic has 1 hour 36 minutes. So it is just 10 minutes extra time which is required. Then cost effectiveness, there is increased base system setup, operational cost, maintenance cost, disposable, pre-operative planning, radiology cost. However, on a broader perspective, savings are driven by lesser readmission rates, implant longevity, shorter duration of hospital stay, lesser needs of opioid and analgesics, lesser instrumentation and sterilization cost. However, this cost effectiveness will be achieved only after volume of arthroplasties via robotic systems. Limitations, yes, it has a higher installation cost, additional radiation exposure to the patient for CT scans, usually only for image-dependent bots. Then a limited compatibility of implant designs due to closed systems. Then we have a learning curve for a comparable operative time. And many studies have shown that there is no difference in midterm and long-term follow-up, and lack of very few randomized control trials are there to adequately prove outcome data. Complications, even these have common complications like periarticular soft tissue injury in case of non-haptic type of systems, then patellar tendon ruptures in case of fully active systems, patellar fractures, peroneal nerve injury, supracondylar fractures. Then supracondylar fractures and tibial fractures can also happen because of the navigation guide pins that are needed to be inserted for the navigation of robotic purposes. Then possible unexpected robotic arm movement technical failures. Then inadequate data for incidence of deep prosthetic joint infections. There is no I couldn't find any paper which says that particularly because of robotic there is increased deep prosthetic joint infections, or maybe even reduced. And also there is no technical or software related complications in most of the papers. So in conclusion, robotic knee arthroplasty provides overall improved patient satisfaction rates following a primary TKA. Newer generation robotic designs are constantly improving in consideration with various pros and cons of previous generation robots. Economic burden related to robotic arthroplasty needs to be addressed, and larger randomized control trials with longer follow-up are needed to appraise a stronger conclusion regarding its use. So even my previous bosses from South Korea believe that robotic knee arthroplasty has several advantages, including accurate alignment, no outliers, and patient-specific functional alignment. And they have a very high potential to take over conventional arthroplasties in the future. These are my references.
Okay.
Thank you so much.
Thank you, Dr. Amit. But you took 9.5 minutes to complete the presentation. So over to judges for questions.
Okay, so really sorry for that.
No issues.
Since it was a very huge topic, very broad this thing, so it was very difficult to cover more things.
Amit, you have done an excellent job. You have covered almost everything and detailed analysis of these robots. But I'm
Thank you,
surprised that you didn't include two more commonly used robots like UVs and Velis.
Yes, actually I have listed that, but there was inadequate data that I couldn't find online. So there was not much data to actually put everything in that. But yes, we do have this QVs and Velis both, right? QVs by Merrill and Velis is by Depew. I know that.
Yeah. That is the thing. And you are using robots?
I have assisted robotic in my during my fellowship in South Korea, but in India here I haven't used robot.
Okay.
Yeah.
So what do you think is the single most advantage of robots compared to conventional surgery?
Perfect.
This is the important point which the advantage of robots compared to conventional surgery.
Yeah, the single most advantage, if I would like to say, it will be perfect component positioning. It is more precise component positioning as compared to conventional TKA.
So alignment.
Alignment, yeah.
Alignment is the most important thing. And number two, prevention of soft tissue injuries.
Yes, that is second most important. Minimum soft tissue dissection and minimum soft tissue injuries are expected in robotic TKA. I think there's some network glitch.
Okay, so shall I ask my question then?
Yes, sir, go ahead.
Yeah. Okay. Yeah. So Amit, congratulations. Nice presentation. Very comprehensive.
Thank you so much.
Tell me, it is claimed that the pain relief is much better after robotics than after conventional.
Yes.
Now, how much of that pain relief is attributed to intra-articular injections and to regional blocks, and how much of that is down to robotics?
See, basically, it is because of robotics. There is least soft tissue, very minimum soft tissue dissection, as well as we have to do very minimum ligamentous or soft tissue release in order to while doing balancing, since everything is decided pre-operatively. Also, there is no need to place intramedullary jigs for achieving the alignment. So all these are the factors which actually help in reducing the post-operative pain. And even whatever the residual post-operative pain is, we can take care of it with the intra-articular injections and our cocktail and things like that. Yeah.
Okay, thank you.
Yeah, very nice presentation, Dr. Amit. It was very comprehensive. Congratulations for that. So the debate now, or the only question in contention is, there was an appraisal of PROMs. You're aware of patient-reported outcome measures. Okay, so PROMs were something that have come up big time in this decade. So the whole problem with robotics now is we are comparing basically accurate placement to patient-reported outcome or functional measures. I think that is the crux of the issue into acceptance of robotics. There's no comparison as to whether you can accurately place an implant with robotics, because a beginner can be as good or he can accurately place the implant as his bosses as well. So that is, I think, the tussle. What is your take on that? And have you read a paper in Bone and Joint Journal by Clement recently?
First of all, I don't think I read that bone and joint paper, what you're talking about. But as far as the patient-reported outcomes are concerned, yes, I think patient-reported outcomes are better. And now this situation is similar to what this concept of kinematic alignment has come into picture in these days. It is something similar. Like we have seen a lot of post-operative X-rays with the kinematic alignment, where the tibial component or even the component, it looks something that is not at all into the mechanical alignment or the axis. However, these are the patients, or these are the where we actually say that however the patient-reported outcomes are better in kinematics. So this is I agree with you that this is a topic of debate again. whether the component placement is really what we should really worry about, whether patient-reported outcomes or the mechanical alignment. And yes, we can still agree to it that with with relatively lesser mechanical alignment, we can have in future component loosening. So for that, we will need longer trials and randomized control trial, maybe 10 years, 20 years follow-up we might need. And since these robotics are relatively new, and especially since I think 2018-19, we have started doing it in India. So I think it will take some time to understand whether only the patient-reported outcomes are the factor, or even component loosenings and all these long-term complications are arising with robotics or not.
Right, right. And also the application of robotics to complex needs that we get is again another debate that most of my bosses will also agree here on this.
Yes, yes,
okay,
yes.
so
wherever,
overall, we have a long way to go.
Right.
Yeah, Mohanty sir, you have a question?
Yeah. What is the advantage of navigation over the robots and advantage of robot over navigation?
As per the studies that I have read, since in navigation, what happens is the system only tells you where to cut and how much to cut, but the cut has to be taken by the surgeon himself. But when it comes to robotics, the robot will actually help you and prevent you from cutting any excessive or any undue or unexpected tissues by restricting your saw or by retracting your burr by a mechanism. So advantage of robotics is that it does not allow for soft tissue injuries to occur in case of this thing. And however, advantage of computer navigated, what I read in previous papers are that there is no long-term advantage of computer navigated over robotics. However, the only advantage of computer navigated over robotics is the price factor. So cost factor is the only this thing. Robotics has a higher setup installation cost. So that is it.
Okay. Thank you.
Okay.
Thank you, sir. Thank you so much.
So I think we have come to the end to this first episode of BOS Rising Star. I'll thank all the judges, and I'll request them to give some tips for encouragement for the participants of future episode, since this is the inaugural one and we are all learning together, getting insights together. Please share your comments, sir. So Mohanty sir.
Yeah, all the presentation are good for that, for their at present to their status and all. But thing is that you can make your presentation more interesting. Okay, like whenever you are presenting, first draw the attention of the crowd that something you so, not that writing that introduction with full sentence, totally arthroplasty or total knee arthroplasty is a very successful operation of the century, that everybody knows what you are going to tell. So like that, rather than starting like that, you start with something boom, some thing which catch the attention, or something is going to tell us probably. That is the first thing to do. And as usual, the slides, the PowerPoint slides, there should be at only maximum 5 to 6 lines should be there. And rather than full sentences, you should be short forms. And here, whatever the marks are given, it is given as per what is your presentation skill, content and structure and organization. How you have structured your presentation. How did you search your literature? For example, Amit presented like he wanted the objective of his presentation, how he PubMed search and all these things he has done. Like that, for example, like that, you should have your objectives, what you are going to present. You should show at the end of it, and you must give some take-home message and make it little bit more pictorial rather than making it entirely text-based or something like that. Put in between some pictures which will, which will be pertinent or relevant to your presentation. Not too much of cartoons, but 1 or 2 cartoons or maximum, that would be okay. But cartoons sometimes draw the attention rather than the texts. So these are relevant points, and again, thank you for presentation. I liked all the presentation. Also learned a couple of things. Taken couple of screenshots also from your slides for my future reference. Thank you very much. It has been very useful, the last 1.5 hours or so. And I thank the President of Bombay Orthopedic Society, Dr. Sanjay Dhar, Dr. Neeraj Bilani, and Dr. Ashraf Shaikh for inviting me here. Thank you very much.
Thank you, sir. Sawan, sir.
Yeah, so it was a very nice experiment and it went off very well. So congratulations to the organizers to do it so well. I think for the rest of it, Mohanty has covered most of it. Only one thing which I have not taken into consideration in marking here is that the presenters, some of them were very professionally dressed with professional backgrounds. And though it was not in our rating here, but I think others can learn from them. And it gives it a good professional look. But that has not been included by me marking that. So I must make that clear. But that is one thing that will...
You have bonus marks, Milind.
Bonus marks.
Sorry?
You have option of bonus marks. So
10 marks, bonus marks.
No, I think that will be unfair. So I think that will be unfair to mark on that basis. But just a suggestion to the presenters.
Yeah, no.
Thank you.
Yeah.
Thank you, sir.
So, let me thank. This is completely the brainchild of our president, Dr. Dhar sir. I'm feeling bad that we didn't have this kind of a contest during our PG days. So I'm feeling really bad for that. But yeah, it is a good bridge between young Turks speaking directly to their bosses. I think it bridges the gap very well these days. It gives us a very scientific attitude towards our practices. Only one tip that I would give is for future references is, yes, there is a lot of literature. Try and be as pertinent and specific to your studies that you refer to. Have a little narrower perspective rather than putting and showing all. If you have a presentation with some literature, you don't have to put a snapshot of the entire paragraph. I think just the take-home message, I think that will make a lot of sense in perceiving your slide. If you have 8 minutes of presentation with around 30 slides, your slide just snaps through within 1 or 2 seconds, which we can't really get the point if you do not mention it. So I think it makes sense in having little text on your slides and being very, very narrow, pertinent, and very sharp about what critiques you make. I think that will make a lot of sense. But I really appreciate all the speakers today. It is a fantastic effort with very, very broad topics, and they've managed to do a very good job. So thank you for that.
Thank you, Anu. I invite Dhar sir to say a few words about the program today. Go ahead, sir.
Yeah, no, all of them were excellent presentations. In fact, I always believe that new talent brings a lot of freshness and newer insights into these topics, although we have all at some stage or other presented these topics in different fora. But as we could all see, and I'm sure what Mohanty said, that there is a lot of freshness in these presentations, and all of them were really excellent presentations. And even I have learned few things today from these presentations. So keep it up, and I'm sure all of you will be now the newer kids on the conference fora. So you will be definitely invited. Yeah, one of you may be winner today, but I'm sure all of you are now in the limelight. So that is the whole point. So thank you very much for being there. And I wish you all the best for your future endeavors. And I'm sure you will come to know about the winners and all in the next few, maybe a month. So thank you, judges, for being there, Milind, Subhranshu, and Anup. It is really nice of you to be here and spend your time with this. And I'm sure this will go a long way in promoting this event in future. Thank you very much.
Yeah, Dr. Neeraj, any technical tips or comments?
So only one for all of you, that whenever you are presenting, all of you are presenting almost either for the first time or maybe for the 5th or 6th time. So you should always first, with a friend or with a teacher, if you are in an institute, present in front of them. Prepare your presentation in advance. Install all the apps required on your laptop. Test it out with somebody who's sitting not in your room, at least somewhere, especially in a different city, on the internet. and present in front of him as if you are presenting in front of us. So that will help you clear out all the doubts, all the issues which you will face with Zoom or anything. And about the PowerPoint, there is a nice workshop which we conducted on OrthoTV 2 years back. I will just share the links in the group and maybe you can have a look at it. You can just forward and see. They are very long workshops about small tips, but you can just have a look. Thank you.
Thanks everybody, and we come to this end of this inaugural session of BOS Rising Star. We'll see you again soon on Friday evening. So thanks again.
Thank you.
Thank you, everyone.
Neeraj. Good night.
Thank you. Bye-bye. Good night.
Bye-bye. Good night.
Thank you, sir.
Rishi,
Bye.
please
Good
stop
night.
the recording. Stop the streaming.
Thanks, Anup.
Had a nice time. Thank you.
Thank you.
Bye, Mohanty sir. Bye, Milind sir. Bye-bye.
Bye-bye. Forgot to give you that
That's okay.
presentation.
It went well. No
Realizing
problem.
that I'll find out and send it. But
No problem, sir. Went well.
no issues. Thank you.
But had a nice time. Thank you, sir.
Thank you.
Thank you. Bye-bye.